Thank you, Professor Vanathi. I'd like to thank the organizing committee for the kind invitation to speak in this symposium. These are my financial disclosures. Recently, the APA CRS published a book on the principles of preferred practice in the management of ocular surface and cataract and refractive surgery. You can download this book for free at the APA CRS website. And so what is the aim of this book is to provide guidelines according to the levels of evidence and grades of recommendation for the management of dry eye after surgery. So this book was developed by a work group that was commissioned by the APA CRS department. And this is the work group. The editors are myself, Professor Tong from Singapore, Professor Yong from Korea, and the expert panel of reviewers are from the EXCO committee at the APA CRS. And this book is supported by the educational grant from Santan. All right, so what are the levels of evidence? Whenever we look at the literature, we should look at the levels of evidence, level 1 to 4. 1 is evidence, 1A, evidence obtained from meta-analysis of randomized control trials. 1B is obtained from at least one randomized control trial. Level 2 is evidence obtained from one well-designed control study. 3 is evidence from comparative studies, case studies, and 4 is from expert committee reports. And grades of recommendation is according to the evidence levels. Grade A is from evidence level 1. Grade B is evidence level 2 and 3. Grade C is evidence levels 4. And good practice points are the best practice in the clinical management. So why do we manage ocular surface? Of course, we know that dry eye and ocular surface disease is so common, not just in the elderly, but also in our refractive patients. And it affects the preoperative biometry, which is very important. You want to consider premium IOL, and also topography for our LASIK screening cases. It also affects the postoperative outcome, the visual refractive results, and the tear and the ocular surface control. And how does the surgery affect the tear film? First of all, it causes inflammation. It can affect the tear stability, the MGD, and it can affect the mucin production due to goblet cell injury, and it can also cause neurological injury by especially refractive surgery. And the preoperative assessment, very important to take an ocular history. Symptoms of dry eye, previous eyelid surgery, previous contact lens intolerance. Systemic history is important. Autoimmune disease it is known to cause a significant, be a risk factor for significant post-op dry eye. This is a grade B recommendation. And if your patients are depressed and on antidepressants, that can also, the medication can also predispose to dry eye. And diabetes, very common in Singapore. 10% of our Singaporeans are diabetics. And this is a caution for refractive surgery. And it may have keratopathy and corneal neuropathy, similar to dry eye. And it may take a longer time to heal, epithelial healing. So this is a grade B recommendation. How about the meibomian gland disease prior to cataract surgery? Very important to remember that the extent of post-cataract surgery, tear lipid thinning and meibomian dysfunction is related to the pre-op severity of MGD. So it's important that you need to optimize your patient before operation, and this is a grade B recommendation. So examine, the rest of the examination will be the tear breakup time, tear meniscal height, fluorescein staining, Schirmer's test, and then you can also do confocal microscopy to look at the corneal nerves. Remember to lift up the upper lid, very simple test to check for conjunctival staining. And biometry, in cases with raised tear osmolarity, the keratometry should be repeated when tear status is returned to normal. This is a grade B recommendation. Very important to note, if your biometry is not consistent, you treat the dry eye first, ask the patient to come back again, repeat the biometry. And so it's important to note, delay your surgery if your patient has significant pre-op dry eye and ocular surface disease. Treat it first before proceeding to surgery. And intraoperative factors, remember to minimize conjunctival manipulation, don't manipulate too much, minimize operative time. And for refractive surgery, it has been shown that SMILE is better than LASIK in terms of dry eye symptoms at 6 months. This is a level 1A evidence here. And LASIK, for LASIK, the corneal hinge position has a minimal effect. There's no difference between a microkeratome and femtosecond laser procedure. Level 1 evidence. And for cataract surgery, larger incisions take longer time for corneal sensitivity to recover. So this is a level 1 evidence. And how about femtosecond cataract surgery? Femtosecond cataract surgery, takes longer, so it has been shown to have a greater OSDI at 1 week, level 2 evidence. So how do we treat dry eyes post-cataracts and refractive surgery? So of course, the first-line treatment, artificial tears. And preservative-free artificial tears recommended for post-LASIK because you need to apply so frequently, preservative-free is recommended. How about for meibomian gland disease? Lid hygiene, warm compress, nutritional supplements, topical azithromycin, and oral doxycycline have been found to be effective for post-LASIK patients. This is a grade C recommendation. And for the oral antibiotics, tetracyclines and macrolides are effective in the treatment of MGD and blepharitis, cases that do not respond to lid hygiene practices. Azithromycin is able to normalize the lipid profile and relieve meibomian gland orifice plugging. This is a grade B recommendation. And for punctal plugs, in post-LASIK aqueous deficiency, dry eye punctal plug treatment improved tear film stability, symptoms, and VA, a grade B recommendation. And topical autologous serum reduces the corneal epithelial erosions and improves post-LASIK tear film stability more effectively than artificial tears, a grade A recommendation. And many publications regarding topical cyclosporin, most of them are grade A and B recommendation, and they show that topical cyclosporin A improved dry eye symptoms, the objective markers and the subjective symptoms over and above that of artificial tears. So it would be beneficial to treat your patients with topical cyclosporin if they have dry eye post-op. And topical steroids, okay, this is, everybody uses topical steroid after cataract or refractive surgery. This should be tapered after 1 month because long-term steroid use is not advisable. We all know the side effects. But for persistent dry eye symptoms, it is beneficial to give another short-term course, like 2 to 4 weeks. It's effective to relieve the symptoms. This is a grade A recommendation. And for non-steroidal anti-inflammatory, that's a word of caution. This may cause corneal melting, especially in patients with severe ocular surface disease. Level 4 evidence. For eyelid warming therapy, this has been shown to be effective in dry eye symptoms after LASIK, a grade B recommendation. Thermal pulsation therapy is effective in relieving obstructive meibomian gland disease and restoring meibomian gland function. And a single treatment may last for up to 1 year. This is a grade A, level 1 evidence. But first of all, you should investigate first and do a meibography, because if it shows that the patient has extensive meibomian gland dropout, you may not want to subject the patient to this expensive treatment because there will not be much benefit if there's extensive meibomian gland dropout. How about lipid-containing emulsion eye drops? It is very effective for meibomian gland disease, a grade A recommendation. Mucin secretagogues, this has recently been released by Sentan, and grade A to B recommendation. It shows that mucin secretagogues can improve the subjective symptoms and the objective markers of dry eye over and above that of the artificial tears. So in conclusion, dry eye disease after cataract and refractive surgery is common, and it may be due to a combination of direct damage to the surgical factors, such as corneal incisions, ocular surface manipulations, indirect damage from the ensuing inflammation. And the symptoms are worse in the immediate post-op period, and they tend to recover over time, usually after a few months. A small percentage of these patients continue to have persistent dry eyes, and these tend to have preoperative risk factors. So it is important to manage patients with the appropriate treatment for their dry eye disease. And it's also important to identify and treat susceptible patients prior to surgery to achieve an optimal outcome. Thank you for your attention.